Today's topic is cellular adaptation, and after I finish today, cell injury is over. The first topic is over today. Next week, I will be Monday. We will try to discuss some questions which you already mentioned in the video. So this is the final topic, cellular adaptation. This cellular adaptation happens following head like introduction, cellular changes in response to stress, which I have already mentioned, and just make a mention of it once again. Then various stages indicated, and finally conclusion.
Sir, sound. Sound.
Hear me now? So, I'm going to show you a picture. This is a cellular changes in response to stress, and this is the part that we will be dealing with. What happens to normal cells? Yes? What happens to normal cells when it undergoes stress? First and foremost is undergoes adaptation. Now, how to explain to you the slide again because I've already explained it to you, and if you have a problem, you can always ask. This slide giving explanation, it has already been explained. Do this slide giving explanation, or should I explain once again? If you tell me yes, I'll explain. Otherwise, I'll provide you for a good proceed to the next slide. Should I? You want me to explain? Okay. Okay, wait. One person has said yes, I have to. So this is basically a normal cell. When the cell undergoes stress, it adapts. So that is adaptation. Like you adapt from the environment. You change your dress, or wear warm clothes, and that's how you adapt from hot to cold to the environment. So when the cell undergoes stress, first and foremost thing what it does is it adapts to the new state. In case the stimuli is the cell fails to adapt, it undergoes, there is inability to adapt, the cell undergoes injury. Or if the stress is quite severe, the cell undergoes injury. If the injury persists, if the injury is mild and transient, the cell returns back to normal, that's reversible cell injury. But if the cell injury persists, it is severe and progressive, and it keeps on persisting, the injury does not abate, the stimulus does not abate, the cell goes into an irreversible state, which is manifested by death of the cell. The death of the cell is either by necrosis or by apoptosis. This is simple. Now let me get into adaptation straight away. So look at this picture. Anyone over here who loves dogs, can you check the name of breeds of these two dogs? Yeah? This is a Siberian Husky. Sure. It's not exactly a Siberian Husky. It's a very close relative to the Siberian Husky. Have you heard of Alaskan Malamutes? This is an Alaskan. What about this one? Yes? It's not a boxer. I don't think I've heard of it. Maybe it's not a boxer. Yes, you know? No, boxer. Boxer have a flat face. It's a South African mobile. Okay, anyway. So what is the difference between these two dogs? One is a South African mobile, one is an Alaskan Malamute. So what has better to do with this? One lives in the savannas of South Africa and another living in the wilderness in the whole harsh environment of Alaska. So what has adaptation to do with it? The fluffy fur. The fluffy fur, that's how animals or any living beings adapt. Similarly, our cells adapt to harsher environment. This is the reason why I have this picture. One is the South African mobile, which is much more muscular, doesn't have fluffy fur. On the other hand, an Alaskan Malamute, which lives in the harsh wilderness of Alaska, with full of snow all around the year, it has more fluffier fur. That's how animals adapt. Similarly, our cells adapt to harsh environment like this. They are similar. Okay. So what is adaptation then? First and foremost thing is adaptation is a reversible change. Adaptation is a reversible change. It is not irreversible. If it is irreversible, it goes into what? Cell injury, cell death. So this is reversible. The most important criteria of adaptation is that it is a reversible change of structure, function and metabolic activity of the cells. Of structure, function and metabolic activity of the cells in response to what? In response to some physiologic stimuli or some pathologic stress. In response to some physiologic stress or whatever other you can explain it. In response to some physiologic stress or pathologic stimuli. Where achieved, where a new alternate state is achieved, which helps the cell to survive in the harsher environment. So the first and foremost thing is a reversible change. Adaptation is nothing but reversible, it is not irreversible. Adaptation is a reversible change of structure, function and metabolic activity of the cells to physiologic stress or metabolic stimuli, whereas any new state is achieved which helps the cells to survive. So once the stimuli is taken off, the stress is eliminated, the cell reverts back to its original form. That is adaptation. So this is how you must remember the points. It's a reversible change of what? Of structure, function, metabolic activity of the cell in response to what? Some physiologic stress or some metabolic stimuli, where a new state is achieved, which helps the cells to survive. Remember this. So there are various forms of adaptation. How the cell adapts? Whether it's atrophy, hypertrophy, aplasia, and metaplasia. Many of you may read in the book that there is a dysplasia also, but dysplasia is not a form of adaptation. Let me make this point very clear because dysplasia is precancerous. It's not precancerous, it's into cancer. It is endoneoplasia, it is not metaplasia. So don't get confused with dysplasia. Dysplasia is disordered growth which will talk to you when we teach you nucleation. That's when we will teach you dysplasia. But metaplasia, the various forms of metaplasia include atrophy, say something. Metaplasia can be dysplasia. Yes, I'm going to explain it. Yes, of course, yes. But dysplasia itself is into cancer. Like CIA, cervical intraepithelial nucleation. Okay. So no cell will adapt in a way where it is going to land into cancer. Nature will not allow that. If that happens, that means there has been some kind of genetic aberrations which has taken the cell into a dysplastic form. Dysplasia is more or less irreversible. If there is dysplasia, you can automatically assume almost a precancerous stage. Metaplasia can be precancerous, it can be a breeding ground of malignancy, but per se it is not malignant. There is no genetic aberration in case of metaplasia. But again, if the stimulus keeps on persisting, you can go into dysplasia. So there are various forms: atrophy, hypertrophy, hyperplasia, and metaplasia. Coming straight into atrophy. What is the meaning of sensitivity? What is the meaning of the word atrophy? Reduction in the number and size of the parenchymal cells. Reduction in the number and size of the parenchymal cells leading to what? Shrinkage of the organ. Reduction in shrinkage of the organ. Or shrinkage of the organ will be what? You will see reduction in the size of the organ. So first and foremost thing is reduction in the size of the parenchymal cells, size and number of parenchymal cells, resulting in reduction in organ size. Is it clear? So if you look into this particular slide, normal cells, and look to the right, on the left is the normal cells, and to the right is the reduced size of the cells. Okay, so that is atrophy. So the first and foremost thing is you can see the brain. What kind of an atrophy is this? What can happen? It can be a physiologic atrophy, it can be a pathologic atrophy. Both. When is it a physiologic atrophy and when is it a pathologic atrophy? Physiologic atrophy will be age-related. But if the same thing, there is ischemia and blood supply is cut off to the brain, that's when it can undergo atrophy. Senile degeneration of the brain. That can be pathological also. For example, look into the palm. The normal pyramid is the right hand side, on the left hand side, and the pyramid is atrophy on the right hand side. What kind of atrophy it may be? Because of compression of some kind of nerve. No, it's not here. See, everything can have physiological. I'll explain it to you. Hypertrophy and hyperplasia, they're hand in gloves. I'll explain it to you. It can happen both in case of physiological atrophy and pathological atrophy depending upon the underlying cause. types. So this is how it was mentioned. One is physiological atrophy. If someone asks you, give an example of atrophy, don't just straight away start giving example of atrophy of tissues, innervation atrophy, ischemic atrophy. No, not like that. You must divide it into physiological types and pathological types. So what is physiological atrophy? Physiological atrophy generally takes place. Most common type is during embryogenesis. You have studied in embryology. I'm reading over. Your knowledge is much more than you should like me rather than me. So during embryogenesis, for example, the atrophy of the uterus and endometrial duct, not the cyst. I mentioned cyst because I'm in pathology. It don't access God, it's by mistake. It just me up. It's endometrial duct. Okay. Now forget embryogenesis. In adult life, when it can happen? Postpartum uterus. Postpartum uterus, right? Why? Because estrogen is cut off. Postpartum uterus, or rather, post-menopausal will be even better. Post-menopausal. Sorry. Then comes pathological atrophy, atrophy of disuse. What is atrophy of disuse? Take example of a patient who has had an accident. There is a plaster cast. There is a plaster cast. The muscle is not into any function. So the muscle fibers will undergo atrophy. That is atrophy of disuse because the muscle is not in use. And in such kind of patients, for example, in case of cancer patients with this atrophy of disuse, they are getting osteoporosis of the bones also. You know what is osteoporosis? Osteoporosis of the bones also. They are antagonisms. Point number one. Number two is innervation atrophy. The slide which I have just shown you here. When can innervation atrophy happen? What can innervation atrophy do? It supplies the muscle fibers. Nerve supplying the muscle fibers. If the muscle do not get the stimulus from the nerve, they can undergo atrophy. Right? Then comes ischemic atrophy. Again, in case of brain. For example, there is atherosclerosis of the vessels supplying the brain. There is no nutrition to the brain. What can happen? The brain can undergo atrophy. Clear? Ischemic atrophy. Number 4 is malnutrition. What can happen in malnutrition? Give an example of malnutrition atrophy. Marasmus. Don't say gout. Say marasmus. PEM, protein energy malnutrition. So don't say PEM straight away because PEM has gout as well as marasmus. So be very specific. Say marasmus of PEM. Don't say because if you just say PEM, then again example the sleeping dog. Don't start asking of gout. You may not answer. So be very specific to marasmus. What can happen in case of marasmus? What happens in case of marasmus?
Wasting of muscles of hand.
Because of protein deficit, there will be energy supply. The body needs energy. So where will the energy be supplied from? From the first of all, from the fat deposition. So the fat will be depleted. Then from the muscle will undergo shrinking. In case of what else? Malnutrition, marasmus is one form. Then what? Give other examples. Kwashiorkor is not Kwashiorkor. Other examples. Forget PEM. Give other examples. Give other examples. Give other examples. Starvation. Yes, starvation. Starvation, malnutrition, what kind of? How can you say? Think something else. Huh? Cachexia. Cachexia is a clinical presentation. Why do you get cachexia? Marasmus, no? Cancer patients. Yes. In case of chronic inflammatory diseases, there will be release of what? Tumor necrosis factor. This tumor necrosis factor will cause cachexia. Cachexia, then what is exactly cachexia? Because the tumor cells, they steal the nutrition from the normal cells. That's why these patients undergo, they become cachexia. Malnourished. So cancer is one form. Malnutrition is okay. Kwashiorkor, marasmus here mentioned, fine. Then also talk about cancer. Also talk about this chronic inflammatory diseases. Where tumor necrosis factor helps in atrophy. Thus, the other use of what helps in atrophy. Loss of endocrine function. Loss of endocrine function, like the endometrium or the uterus, they undergo atrophy because of loss of estrogen. Then comes pressure atrophy. Pressure, space of mind, yes, give an example. Give an example in brain. What else? Get a lipoma, lipoma looking at tumor of the lips, which says there's a lipoma in the neck, or there's a lipoma somewhere in the body, or any kind of space of condition, as he has said, which can, how does pressure cause atrophy? Pressure that either compress a nerve, or you can compress a blood vessel. You can compromise the affected part out of a signal from the nerve or out of blood ischemic. So that's how they are hand nerves. That's how they are hand nerves. Okay. So here now, physiological atrophy means atrophy of protocol and cause duct during genesis. Then you have pathological atrophy or post-uterus rather. Then you have the pathological atrophy. I'm not going to explain everything. But you keep the heading and you have to read the book and study. You keep on asking you what is the best book for postgraduate, the best books in province, for undergraduate. Okay, this is down line. What is the book? What happens? He studied province. This is by far the best. You know what they said? That is only for general authority. That's not system. It's only for general authority. Okay? So coming to the mechanism how it happens. So when there is increased cell size, what happens is the metabolic demands comes down. Because the cell reduces in size, the cell shrinks, the metabolic demands of the reduced cell is low, and this allows the cell to survive during that period. So an equilibrium is reached because the size of the cell is cut down, the size of the cell is reduced. It needs less energy to survive. The metabolic activity of the cells is reduced and it needs less energy to survive. So an equilibrium is reached where the cells survive. But to this extent it is reversible. But if the stimulant keeps on persisting, the cells go into an irreversible state. And here, the cells die. Okay, this is the point that you have to remember. So what is the mechanism? How the cells die? Again, there is increased protein synthesis. So the backbone of the cell is done basically. So you are very careful. Spinal cord human or just take an example. Spinal cord cell is broken, backbone is broken because of increased protein synthesis, as well as there is increased degradation. And there is another method called autophagy. Now when you write the answers, just don't mention increased protein synthesis, increased degradation. You have to write 2 or 3 lines under it. What is autophagy? You have to mention, you know what is autophagy? Autophagy, the cell takes its own contents. The cell takes its own contents. That is autophagy. Remember that. And this, they present as death in the plasma membrane. That question would have been this. What does it cause? Brown atrophy. What is it called? Answer, brown atrophy. If you speak too much, I'm going to ask you a question. So you must be very specific. But good, I appreciate it. Congratulations. Okay? Is this clear? Should I go to the next slide? Atrophy. Okay, look into the normal cells and look into the increased size of the cells. Right? Here are a few points worth mentioning, which you must remember is, again, atrophy is increasing size of the cells, which results not increasing number of the cells. Atrophy is increasing size of the cells. You know why there is no increasing number, but there is increasing size? Because hypertrophy generally takes place in non-dividing cells. And in the dividing cells, the cells can undergo both hypertrophy and aplasia. The cells can undergo both hypertrophy and aplasia. So increasing size of the cells resulting in increasing size of the organ. It generally takes place in non-dividing dividing cells like the cardiomyocytes, the skeletal muscle cells, the striatal muscles. How? It do not undergo division. For example, the biceps breaker. Whoever does gym over here can tell me, must be formed. Huh? Who does gym? You do gym, what is it called? Bicep pressure exercise for? Huh? Okay, fine. So this is just an example. The cells undergo hypertrophy over here. It takes place in non-dividing cells. Remember, it happens again. There is a physiological cause and pathological cause. So either it takes place because of increased functional demand, which is mostly seen in people who does a lot of developments. There is increased functional demand. There is stimulation by hormones and growth factors. For example, in case of uterus again, if uterus can undergo atrophy, the same thing can also undergo hypertrophy and activation. Right. And the last is chronic hemodynamic overload. Chronic hemodynamic overload is seen in which organ? The heart. For example, in case of systemic hypertension, for example, in case of some kind of mitral valve stenosis, some valvular defects, chronic hemodynamic overload. So there are three things you must remember. One is increased functional demand, which is mostly physiological. Okay. Then you have the stimulation of the organs and growth factors, and finally you have the hemodynamic overload. So these are the three stimuluses which you must remember in case of hypertrophy. So again, this is an example of the physiology in case of a pregnant uterus. Pregnant uterus in case of the hormones. Okay, estrogen, hormone induced. Then bulging muscles. So this percentage can be just Ronnie Bowman, yes. Who said that? Who said that? Ronnie Bowman, that's right. Okay, fine. So in case of a pregnant uterus, which is hormone induced, and in case of bulging muscles, in case of people who does a lot of workouts. Who does a lot of workout? That is because of increased functional demand. This is what physiology. Then coming to pathology, hypertrophy, cardiac muscles. In case of chronic hemodynamic overload, you can look up, you can see this normal heart, the left ventricle, and you can see on the right hand side the hypertrophic cardiomyopathy, where there is enlargement of the muscle of the heart. So that is in case of systemic hypertension or chronic hemodynamic overload. Then you have the stool muscle, cardiac muscle, then you have the stool muscle. In case of mitochondrial stenosis, you know what is the mitochondrial stenosis? You must have studied. Look into the stomach, junction of the stomach and duodenum on the left hand side, which is long anatomy. Then because there is activation of the stool muscle of the duodenal junction, gastroduodenal junction, and there is a stenosis. Okay, there is narrowing of the lumen. Then you have in case of skeletal muscle. In case of skeletal muscles, and finally compensatory hypertrophy. Compensatory hypertrophy takes place where? Compensatory hypertrophy takes place where? In case of liver, in case of, for example, one organ is cut off. Thyroid outcome, yes, thyroid is something. Kidney is hyperthyroidism. Okay. So I have explained this slide. Coming to hyperplasia, this is a very small topic actually. Hyperplasia is a very small topic. Then coming to hyperplasia, hyperplasia is what? Increasing the number of the cells. Increasing the number of the cells in the organ of tissue resulting in enlargement of the organ. Isn't it simple? Hypertrophy and hyperplasia is very simple. Hypertrophy is increasing size of the cells. Hyperplasia is increasing number of the cells. Hyperplasia is increasing number of the cells resulting in increasing the size of the organ. What happens because there is recruitment of the cells from the GPCR phase of the cell cycle into mitosis? Obviously, because it happens in both divided and non-divided cells, so what can happen in case of a cell which is undergoing division? Mitosis. Mitosis. So cells from the GPCR phase of the cell cycle will be recruited into hyperplasia, into mitosis, and that's how cells will divide. Okay. So there are two types of cells which undergo division. One is the dividing cells and the other is the stem cell. So what are the dividing cells that undergo hyperplasia? Epithelial cells of the skin, mucous membranes, bone marrow, spleen, etc. And then you have the cellular cells. Cellular cells are cells of the liver, pancreas, kidney, adrenal, and thyroid. They can undergo hyperplasia. So hypertrophy and hyperplasia, the basic difference is increasing increase in size of the cells and increase in number of the cells. Hypertrophy, what will happen? There will be increase in the size of the organ, no doubt. Hypertrophy will take place in non-dividing cells, whereas hyperplasia will take place in dividing as well as in non-dividing cells. So this is the certain things which you must remember. And if you look into the slide where normal, I have purposely put this picture, normal cells on the left hand side, hyperplasia means it is increasing number of cells. Okay. So physiological hypertrophy. Physiological hypertrophy generally the most important if you remember endometrium. Endometrium can both undergo physiological hypertrophy as well as pathological hypertrophy. It can undergo both physiological hypertrophy as well as pathological hypertrophy. So physiological hypertrophy, when does an endometrium undergo physiological hypertrophy? Pregnancy chhara we know very common example. Menstrual cycle. Menstrual cycle is an example of physiological hypertrophy. Correct? When can the same endometrium undergo pathological hypertrophy? In case of estrogen excess, there will be endometrial hyperplasia, and this endometrial hyperplasia can be a breeding ground for malignancy. Remember that there is endometrial adenocarcinoma which can undergo because of excess estrogen in the body, which can be endogenous estrogen formation in the body, which can be exogenous. For example, some kind of medicines, the woman is saying, okay, that's an exogenous estrogen. So endometrium can undergo both kinds of hyperplasia. One is physiological hyperplasia, which happens in case of normal menstrual cycle and menstrual. Especially over with the hyperplasia of the endometrium before it prepares for the next phase of the menstrual cycle, next period. Okay, so endometrium must undergo regeneration again before it prepares itself for the next cycle. So that is physiological hypertrophy. The same endometrium can undergo pathological hypertrophy when there is excess of estrogen. Okay, so that is example of pathological hypertrophy. That's what I have to see now. This is again compensatory hypertrophy again. And physiological, one must remember the breast, the female breast. The female breast in child versus the female breast in puberty versus the female breast during pregnancy and lactation. How they undergo hypertrophy. Everything is in the granular area. Isn't it? Under which hormone for that example in case of lactation, cells will undergo hyperplasia because of the granular area hyperplasia. Isn't it? So remember this thing. If you remember the endometrium and if you remember the breast, which is by far the easiest to remember, you get a lot of it. Don't worry about it. Remember the female breast and the endometrium. Okay. So what is hormone induced? Which are explained. Female breast, just which are explained in child, versus puberty and lactation. Again, pregnant uterus, same thing. Pregnancy is of course normal thing, and endometrium after a normal endometrial cycle. Liver. When one lobe undergoes, when you cut off one lobe, and then automatically after nephrectomy. Then comes pathological hyperplasia. Now the female reproductive organ is over. Let's get into the male reproductive organ. What is this? Benign prostatic hyperplasia. Benign prostatic hyperplasia, which you have studied, which is the most common cause of retention of urine in pediatric males. Which hormone? If estrogen is the cause of endometrial hyperplasia, which hormone causes? Testosterone, androgens. Under the influence of androgens, the prostate will undergo hyperplasia. That is one thing. In case of warts, which I have here, you can see, I have the same thing. I excised it in 2012 and again it recurred. So after that I haven't done it. Maybe I have to go for a trial. I have the same thing. You see that side, you know which might recur. It happened. Okay. So if you go back over here, you can see this hypertrophic stratifying squamous epithelium. You know what is the stratifying squamous epithelium? Then the spectrum on the right hand side, it's a case of pseudo-epitheliomatous hyperplasia. Have you heard of this term, pseudo-epitheliomatous hyperplasia? Pseudo-epitheliomatous hyperplasia means the stratified squamous epithelium of the skin. It undergoes hyperplasia, mimicking a malignancy. Pseudo, or also called as pseudo-carcinoma. Pseudo means false. It is not a malignancy, but it can mimic a malignancy. Pseudo-epitheliomatous hyperplasia of the skin. And finally, on the right, the picture on the right hand down, what is that? There's a schematic representation of something. It looks like a blood vessel. You try, but not exactly a blood vessel. I want you to come out with the answer. Because when I'm explaining an organ, if it has a physiological, if it can be exemplified with physiology, it can be exemplified with pathology also. So what can that be? Yes, done for what? It looks like a blood vessel. If I'm at your stage and if you come up with the answer for that, you come up with the same answer, and if you say it's a blood vessel, I'll say it's a good try. But it's not exactly a blood vessel, it's a breast again. Breast. Okay? That is after the ratio of the breast. What lining the cells have in breast? One is the body epithelium, and what else you have? The myoepithelial cells, right? The myoepithelial cells is helpful for traction. Right? So, in ductal hyperplasia, the everybody of the columnar epithelium undergoes hyperplasia. Right? And they block the duct. See, this is normal. If this is normal, consider this as normal. These are the epithelial cells, right? And over here you have the basement, you have the myoepithelial cells. So these epithelial cells are increasing in number. Don't you think they're increasing in number? So that is hyperplasia. And this ductal hyperplasia in breast is an example of pathological hyperplasia, because ductal hyperplasia can give rise to carcinoma of the breast. Remember that. So this is what I mentioned. Endometrial hyperplasia, estrogen excess which gives rise to endometrial carcinoma. Then you have the skin warts. Can be because of HPV. I don't know if I have a HPV over here or not. Maybe not. Pseudo-carcinomatous hyperplasia of the skin, the which are mimics of malignancy. Then you have the ductal hyperplasia of the breast. And the GPCRs prostate, benign prostate hyperplasia. Give an example because of androgen excess. This is protected. And this hyperplasia can be a fertile soil of malignancy. It can definitely be malignancy. It can be a breeding ground for malignancy. Remember, hyperplasia can be a breeding ground for malignancy. The final one is metaplasia. Metaplasia is replacement of one differentiated cell into another differentiated, use the word differentiated cell. One differentiated cell type into another differentiated cell type. Beta means transformation, plasia means growth. Beta means transformation and plasia means growth. Again, it's a reversible change. Let me make this one very clear to you. It's a reversible change. If there is not one differentiated cell type, another. Most common is epithelial to most common is epithelial. Then comes mesenchyme. Remember, epithelial. Columnar to squamous is by far the most common. Columnar to squamous. We go to say something. Squamous columnar bad practice. You love that word, marriage is a biggest thing. You love that word, marriage is the biggest thing. Marriage is the biggest thing. But not marriage, that's what you know. So, this is the most common one. Columnar to squamous. Where it happens. Columnar to squamous, where it happens. Okay? Physiological is a transient response in case of inflammation where the monocytes transform into macrophages. Remember that. Where monocytes transform into macrophages is not that important. Remember the pathological hyperplasia. It can be epithelial hyperplasia, epithelial hyperplasia, or it can be mesenchymal hyperplasia. Pathological hyperplasias can be epithelial hyperplasia and mesenchymal hyperplasia. Yes, now explain. Look into the diagram. Huh? Columnar squamous in case of what? Segment focus. The pseudostratified ciliated columnar epithelium of the respiratory tract. They undergo squamous metaplasia. Why? Because the squamous cells can survive in the harsher environment. This is epithelial to squamous again. Give another example now. Pancreatic duct, but more than that. Very common. Yes. Go ahead. Cervix, yes. You have the ectocervix and the endocervix. What is the junction called? Anatomy.
Internal orifice.
Junction of the ecto and endocervix where maximum malignancies take place. What is that area called? Yes. Huh? TZ. Have you heard of the transformation zone? No. Sorry, it's called the transformation zone. The junction of the squamous and the columnar is called the transformation zone, where the columnar becomes squamous. That is the most common site of malignancy. Because the most common malignancy in case of a cervix is squamous cell carcinoma. Now, sometimes the endocervical epithelium, in case of, for example, it's a prolapse. There is what is a prolapse? There has been uterine prolapse. Because of uterine prolapse, the uterus is exposed to a harsher environment. The uterus is exposed to a harsher environment where it is undergoing chronic irritation. So the endocervical glands, which are made of columnar epithelium, they undergo metaplasia into squamous epithelium. Sometimes the endocervical columnar epithelium lining can undergo metaplasia into squamous epithelium. This metaplasia can give rise to dysplasia, which is a very common thing. We call it CIL, so like dysplasia, or we may have studied L-cil and H-cil. Low-grade squamous intraepithelial lesion, high-grade squamous intraepithelial lesion, and finally into look at the cervix. Open cervix and front. H-cil, L-cil, the cervix is the one. H-cil, L-cil is the one, or cervix is the one. Look at the picture and see cervix. Female reproductive tract. Then, what are you doing? So, H-cil, L-cil, these are nothing but precancerous conditions. Okay, so metaplasia again can be a breaking down for malignancy. Then, this is the intestinal metaplasia in case of Barrett's esophagus. Barrett's esophagus is columnar, squamous columnar. Why it happens? See? Yes? What kind of metaplasia? What kind of glands did you find? Intestinal glands. Why intestinal glands? Because they have a mucus. In GERD, what happens is there is reflux of the gastric contents because of whatever it may be the reason. The lower esophageal sphincter tone is reduced, it doesn't close properly, so the contents regurgitates into your esophagus. And because the contents of the stomach are acidic, there is erosion of the esophagus. The squamous epithelium, which can survive more, which is more stronger than columnar epithelium, here the squamous epithelium undergoes metaplasia into columnar epithelium. Why? Because to counter the reaction of acid, the intestinal metaplasia that takes place, the mucus that is secreted, which is just because of the mucus that is secreted from the columnar epithelium, which will counteract the acidic content of the stomach. So, GPR. This condition is called Barrett's esophagus. This condition meaning something? No problem. So this is Barrett's esophagus. Remember this stuff. So if you remember through your course, how many examples that will enough to achieve good marks. Barrett's esophagus is made of mention where there is example See, squamous to columnar not critical. Columnar to squamous not critical ask you because it's very common. But squamous to columnar is not very common. So barracks is an example of squamous to columnar lesion. So this is basically epithelial. I explained you the diagram. Now you can understand. Epithelial, first is squamous in case of tobacco, smoking. Respiratory squamous means columnar squamous basically. Then chronic irritation, uterine prolapse, vitamin A deficiency, and then in case of urinary tract, so we have intervention of epithelial stone. The transitional epithelium of the urinary bladder can undergo squamous epithelium. Then Barrett's esophagus. If you remember, cystitis glandularis is fine, but Barrett's esophagus is something that you must remember. In case of columnar to squamous, squamous to columnar. Then comes mesenchymal metaplasia. This is the last one. Mesenchymal metaplasia is seen in myositis ossificans. You know what is myositis ossificans? Have you heard of the term myositis ossificans? Some issue undergo bone transplantation. In case of myositis ossificans, this is very inherited. This is myositis ossificans basically. Mostly sitting, not bone. Myositis ossificans. Okay. See, this is the muscle. You have seen muscles, right? You have seen normally saw your muscles built back. And next to it, you have the bony trabeculae. Bone formation in soft tissues. That myositis ossificans. Then Monkeybugs medial sclerosis. That can be an example of calcification also. Monkeybugs medial sclerosis. Seen in blood vessels. Monkeybugs medial sclerosis. And last is scar in case of chronic inflammation. It's not very common. You can remember the first ones. That is more than okay. Medial soft tissues and bone formation that's called register. Is very common in old age. Okay, if you have not read about it, we will show you if you get this slide. Okay. So this is basically the schematic representation. Normal epithelial cells which is undergoing stress, various adaptations, hypertrophy, hyperplasia, metaplasia, dysplasia, dysplasia, then and reversible and irreversible cells. This finishes the topic. And so before I end, is adaptation unnecessary evil or not? Here the insight is the existence of nuclear power necessary evil. You're not getting into it. Is it the necessary nuclear power? Yes or no?
Yes, sir. Yes, sir.
It shows definitely a picture from the west, which shows a picture probably carrying a Ukrainian flag and those stand in Russia. Is this war justified? Yes or no? Is it a necessary evil? If I ask you, is the Russian-Ukraine war a necessary evil or not? Yes or no? Yes. No. Why yes and no? That's what I'm asking. Yes?
Yes, sir.
On one hand, it is an evil because most of people are dying. On the other hand, it is necessary. You know why? Because this war has exposed America to Dadagiri.
Yes, sir.
Right? Do you agree?
Yes, sir.
No? Sorry?
Yes, sir. That is an American term.
That is?
Sir, that's American leopard.
American tanker.
Sir, that is a leopard, not in Russian term.
I'm not talking about that. I'm talking about the Egypt and the Ukrainian flag and there's an artillery down. So maybe it's the Ukrainian, the Russian flags are developing the Ukrainian things. So is this war necessary or not? On one hand, it is necessary to the right and simple. But on the other hand, it is necessary. You know why? On the other hand, it is necessary because it's going to cut down America's. See, has America dared to attack Russia?
No, sir.
No.
No, sir.
So it has attacked Serbia. It has attacked, it has given threat to the Serbian countries. But it has never attacked, it has attacked India. It has got criticized Iraq. But it has not attacked Russia. Because it doesn't have the guts to attack Russia. And on one hand, on the other hand, Russia is not wrong if you ask me. Because otherwise, if they are Ukraine, they become a NATO member. Russia is surrounded by Ukraine. So shut them out of this Ukraine. If anyone thinks that what is not correct, what's really the Ukraine. Anyway, that's not the point. So, see, other than studies, you know why I explain it? You know why I explain it to you? Because other than studies, you know something also. You can't just be book smart and survive. You have to be street smart. That is the reason why I'm explaining it to you. So you need to know something else other than your book. Do you agree? Yeah? So the objective is adaptation to criticism evil or not? Yeah? It is necessary because it helps the cells to survive the harsher environment. On the other hand, it can be an evil because, for example, in case of adaptation, in case of adaptation, if the stimulus process there is a genetic aberration, the cells will undergo transformation into mechanism. So that is why necessary. It is necessary on one hand, on the other hand, it can be evil. So, what's your opinion? Opinion is yes. Necessary. Okay. So this is your topic. Self-injury and adaptation is over. And one day, Tuesday, Wednesday, we will try to discuss the questions. Just go to the question papers, see what questions came, and we will try to solve your answers. I can't guarantee you will be able to answer the next question of those. But if you take some good questions, maybe you can study and our knowledge will okay? Thank you.
Antagonistic effect. If you look at it, a antagonistic effect, it may be physical, chemical, at the receptor level, or physiological. Physiological means, suppose histamine causes whereas adrenaline causes dilatation. If we give both these drugs simultaneously, none of their effects will be more prominent. So, it may be physical, antagonistic effect can be physical, and chemical can be physiological, can be at the receptor level. So, at the receptor level, there are agonists, antagonists, inverse agonists, or partial agonists. So, in case of agonists, all these are discussed, no? So, agonist, affinity is there or not? If it is 0, it is antagonist. If it is 1, it is agonist. So, what about inverse agonist? Minus of affinity. Affinity থাকবে affinity না থাকলে সাবস্ট্রেটটা ওই রিসেপ্টরের সাবস্ট্রেটই নয় affinity থাকতেই হবে ইন্ট্রিনসিক অ্যাক্টিভিটির উপর ডিপেন্ড করে so if a substrate is a substrate of a specific receptor either it is agonist antagonist inverse agonist partial agonist affinity must be there to be a substrate of that receptor. Here, affinity is there. Then, depending upon the intrinsic activity, it differentiates between agonist, antagonist, partial agonist, inverse agonist. The example of inverse agonist. Benzodiazepine receptor, beta carotene is the substrate. This is inverse agonist. That's different. OCP will reformulation data also. That is enzyme induction and increaser. That is the enzyme. And now we are talking about the receptor. So what are the drugs and how drug acts? Drug can act by acting in a specific molecule or depending upon their chemical, physiological activity. So if there is a target is a modulator to receptor to enzyme, ion channel, and catalyst transporter. Catalyst is target enzyme, receptor, then ion channel. These four are the specific target for a drug, and drug may be act due to their physical activity, chemical activity. Chemical activity example, antagonism. They doesn't have a specific target. Okay. So now competitive and non-competitive. ये तो जाना था. Competitive, non-competitive. अगर कल वाला काफी competitive वाला काफी non-competitive वाला क्या बोल रहे? Competitive का बोल रहे? Competitive have a chemically similar or dissimilar. Very similar. They bind to the same receptor or not? Same receptor. And non-competitive dividing receptor. Dividing receptor. Same receptor but different size. If it is bind, it is not bind with the receptor. It is neither antagonist nor agonist, nothing. It is not substrate of the receptor. So non-competitive bind with that receptor but different size. Chemically different. Now DCR will be shifted towards the right without losing its efficacy is competitive. If in case of non-competitive, its right side shift করবে, downward shift করবে। তার মানে potential কমবে, efficacy কমবে। Potentially, efficacy both reduce in case of non-competitive, and in case of competitive, potency will be less, but efficacy can be maintained. So, if we have described this chart, the first is a sigmoid curve, so it is a closed response curve. It is a log closed response curve, where in the first one, after binding with the antagonist, goes towards the right, but maintaining its efficacy. The ceiling is same, so it is a efficacy will be same with reduced potency. So it shows competitive inhibition. This one is shifted towards the right as well as downward. It is non-gate competition. By increased concentration of the agonist, we can achieve the efficacy in this step. Which type of antagonism? So, if we increase concentration of the substrate or agonist, we can counteract the antagonism in case of competitive one. But if we in non-competitive, we increase, we cannot increase because they bind with the different side of the same receptor, and there is a change of that receptor, configurational change. So, even by increasing concentration, we cannot achieve the maximum dose in case of competitive or non-competitive. Non-competitive, we can achieve it in case of competitive. Here, graph into practical aspect. Competitive, non-competitive. Rightward shift without losing efficacy is competitive. Right side as well as downward is non-competitive. So up to this is clear now. Now we go to the second part. Different types of receptors. These are metabotropic or decoupled protein receptor. Regularly came as a hormone or as a part of the glucose. Next, ionotropic receptor. Then enzyme ring receptor. Gas receptor and intracellular receptor. Pharmacology, in some of the foreign of the group, enzyme is also described as that, and it can also act as a receptor. Or voltage gated ion channel is also can then enzyme, then that and fifth one is intracellular. Among these intracellular, there is cytoplasmic and nucleus. এই কথা যেন লেখা থাকে। Decoupled protein receptor or second messenger, there are 7 alpha helix. So there is a hydrophobic amino acid, 3 extracellular and 3 intracellular loop. Binding site কোথায় থাকে? Extra receptor binding site যেখানে আছে অ্যামাইনো লাগবে extracellular এখানে 3 intracellular 3 extracellular extracellular এর মধ্যে binding site 7 alpha helix. Then it expose the domates like the cytosol, and there are 3 subunits. 3 subunits intracellular extracellular কি থাকবে binding site 7 alpha helical structure তিনটে বাইরে তিনটে ভেতরে বাইরে যেটা থাকে সেটা কি থাকে binding site ভেতরে যেটা থাকে তাতে তিনটে সাবইউনিট থাকে আলফা বিটা গামা এর মধ্যে আলফা is the effector alpha binds with the GDP in inactive state. Alpha binds with the GDP in inactive state. Even substrate comes and binds with the extracellular binding site. Then alpha GDP converts into the GTP. Now what happens? Alpha with GDP dissociates from the beta and gamma. Now primary action is done with the second messengers to the alpha and beta. Clear up this? Beta gamma, they can open potassium channel, they can close calcium channel, and they can also promote GPCR desensitization. GPCR means coupled receptor protein desensitization in the higher rate of activation. And alpha, beta gamma alpha হয়ে গেল। After having the second messenger and subsequent action, what happened? Alpha with GTP. কিভাবে করবে? GTP will convert to GTP by intrinsic activity of the alpha. GTP's activity is present in the alpha. With that GTP's activity, it converts GTP to GTP, and again alpha will bind with the beta and gamma. Clear? কি থাকবে 7 alpha helix 3 outside 3 inside binding side outside inside a alpha beta gamma alpha is bind with the GDP in the inactive state after binding with the substrate it converts GDP to GDP and it dissociates alpha with GDP with subsequently activate the second messengers. What are the second messengers? CAMP, calcium, IP,
IP3.
These are the main. They can be some of them they can counteract action. Sometimes they can help each other action. Now, depending upon the activity of alpha, it can be categorized stimulatory, GS, inhibitory, and GO and DP. GS, they will activate adenine cyclase and open the calcium channel. Whereas in case of GI, adenine cyclase inhibition, potassium channel open up. If there is a potassium channel opening, what happens? Depolarization and depolarization. Hyperpolarization will be there for the, so there will be activity. If there is a contraction or secretion, that will be inhibited. Second messenger is the second messenger. There are cyclic AMP, and calcium IP. Next one is that in metabotrophic the action is in the seconds. In case of ion channels, action is in the milliseconds. In case of ion channel, receptor mediated ion channel, there are another thing is the voltage gated ion channel. So in case of receptor mediated ion channel, there is a binding site extracellularly which binds and open up the ion channels. Ion channels like sodium, potassium, chloride and calcium. So examples is nicotinic cholinergic receptor. Nicotinic type of cholinergic receptor, 5-HT3 receptors, 5-HT3 receptors. These are the ion channels present in the which system? In the primary present brain. Nicotinic cholinergic nicotinic cholinergic autonomic receptor, primarily autonomic, but stand present in DNA. Whereas GABA and glycine, which is inhibitory neurotransmitter in the CNS, excitatory neurotransmitter in the CNS is AMPA, NMDA and kinase. So there are neurotransmitters for the parasympathetic and CNS. In case of CNS, inhibitory one is GABA and glycine, excitatory one is AMP, kinase and NMDA. These are receptor mediated ion channels. Decoupled protein mediated ion channel, receptor, then ion channel, receptor mediated ion channel. Rest 3 are total. আপনি দেখতে পাবেন না? Enzyme, that are intracellular. So it is a pentagonic one, ion channel. Primarily pentagonic one. They have 5 subunits, whereas binding site is primarily close to the alpha site. They bind and directly operate without any intervention of second messenger or coupling protein. In these cases, there is a substrate binding site present in the extracellular space, transmembrane, and there is a enzymatic activity which is required for their action present in the intracellular space. Whereas in case of GAG-STAT, there is 2 portions, GAG and STAT, which is not bind to the receptor of the inactive state. After bind to the substrate, yes, substrate is cytokine, primarily cytokine. Cytokine is an inflammatory mediator. Cytokines, interleukins, like growth hormone, they bind with this receptor and whatever they come close. After that, GAG binds with this receptor and as well as STAT, and they operate the STAT portion. There is 2 portions other than the receptor. There is GAG and there is STAT. GAG is genus kinase action, and there is STAT signal transducer that activator of transfer. That's that. There the next one is STAT, and is weak one is GAG. After now the enzymatic, the basic thing is the enzymatic activity of the receptor is not bind to it is in the inactive state. After activation, first GAG comes bind with the receptor, then they enzymatically transform the STAT and they bind together. Dimer is formed, and this STAT dimer acts the subsequent actions. That is part of what is the difference? Enzymatic activity is not present itself in the receptor. It is not present. Here it requires other substance, not bind with the receptor. And it requires the peptide receptor and peptide hormones bind with which type of receptors? What type of enzyme? Cytokinin, growth hormone, prolactin. These are binds with the JAK site. Clear? Basic difference. The enzymatic receptor itself has a enzymatic activity. For enzymatic action of JAK, they require two different proteins. It is not a part of inactive state of the receptor. Third one is intracellular. Intracellular, there are two types of intracellular. Actual nuclear and the cytosolic. Cytosolic is primarily homodimer, and there is a heterodimer in case of nuclear. Drugs which are attaching to the nuclear one is iodine hormone, vitamin A, vitamin D. These are the nuclear receptors. Whereas different types of steroids, like corticoid, mineralocorticoid, they act as cytosolic. So how this cytoplasmic or nuclear receptor acts? First, the substrate binds with the carboxylic egg. Carboxylic egg of the receptor, they bind with that. After that, there is a dimerization. Then there is a conformational change so that they can bind with the DNA. After that, they come to the cytosol to the nucleus. After that, there are two types of diamond. One diamond is formed. Then there is a conformational change. Now they goes inside the nucleus. Nucleus is our co-effector or co-inhibitor. There is a co-effector or co-inhibitor. They bind with that. So that we have to find the specific portion of the DNA that can produce that protein. Then they bind with that DNA, production of mRNA, and through the mRNA there is production of the protein. And these proteins having that action. Here, it is the carboxylic chain, dimerization, configurational chain, transport inside the nucleus. Then there is a co-receptor and co-activator. They bind with that, so that they are easily bind to the specific sequence of the DNA. Receptor potency, receptor agonism immediate. Receptor agonism immediate. Yes. Receptor agonism যুক্ত করা না তার নাম হচ্ছে সিঙ্গুলার। আলাদা আলাদা তাহলে agonist লাগলো তবে তারপরে কনফিগারেশনাল চেঞ্জ হবে। কনফিগারেশনাল চেঞ্জ হওয়ার পরে সেটা যুক্ত হবে। দিয়ে তারপরে ডিএনএ স্পেসিফিক পোরশনের সাথে বাইন্ড করে এমআরএনএ স্ট্যান্ড করবে। তাহলে এর মধ্যে সবচেয়ে টাইম টেকিং অ্যাকশন দিস ফাইভ রিসেপ্টর উইল বি cytosolic or nuclear receptor. Why? Because it requires protein synthesis, and any synthesis requires more part time. We require this type for action. Ion channel receptor gated ion channel. There are different types of action. Voltage gated ion channel and receptor ligand-gated ion channel. In case of different receptors, there are 5 receptors. Decoupled protein, ion channel, the last one, enzymatic, JAK stack, and intracellular. From receptor to the subject time number, intracellular. Subject one, receptor mediated ion channel. তারপরে decoupled protein, তারপরে enzymatic JAK stack. Peptide hormone acts to which receptor? Enzyme. Cytokines are acts to which receptor? JAK stack. Jack started cytokines, interleukins, growth hormone, prolactin. এই চারটে মনে cytokines, interleukins, growth hormone, and prolactin. These are active through receptor. Jack. Peptide hormone means insulin and different types of growth hormone. Be it nerve-related or internal growth hormone or ANT. All these are and through enzyme. Then nuclear. Vitamin A, vitamin D, thyroid. Vitamin A, vitamin D, thyroid. They act the internuclear. And cytosolic one are steroid. Glucocorticoid, mineralocorticoid, these are the cytosol. That's the rest of everything are going to the now I am going to start here. It is nicotinic, muscarinic, nicotinic. Muscarinic is the nicotinic, GABA-glycine CNS inhibitory neurotransmitter. CNS excitatory neurotransmitter AMP, excitatory NMDA, kinase, all these are
ion channel.
one type of receptor-mediated ion channel, not voltage. ঠিক আছে এবার এগুলো মনে রাখলে বাকি যা আছে যেগুলো রিসেপ্টর কাজ করবে সেগুলো ঠিক আছে ঠিক আছে পেপটাইড গুলো হচ্ছে এনজাইমেটিক ইন্টারলিউকিন গ্রোথ হরমোন প্রোল্যাক্টিন রিজার্ভ জ্যাকস্ট্যাট নিউক্লিয়ার কি হবে ভিটামিন এ ডি আর থাইরয়েড আর সাইটোসলিকটা অল আদার স্টেরয়েড গ্লুকোকর্টিকয়েড মিনারেলোকর্টিকয়েড অল voltage receptor mediated ion channel nicotinic GABA-glycine are AMPA. These are the ion channel